Hello, my name is Dr. Rebecca Buckley, and I'm chairman of the Medical Advisory Committee of the IDF. And I'd like to welcome you to the national meeting in 2021. I was asked to speak to you about a condition that I've been dealing with for the past 4 decades, and something that I know that many of you know a lot about, but I wanted to share with you my experiences over the last 4 decades and to tell you what is currently available in the way of diagnosis and treatment. So with that introduction, I'll just talk about human severe combined immune deficiency, or SCID. So this is a syndrome. It's not a single condition. It was first described by Swiss workers in 1951. And it was characterized by a very low lymphocyte count. But we've learned over the past 70 years that this syndrome consists of many conditions of different genetic origins. And the main characteristic of all of these conditions are that they don't have any T cells. And sometimes they don't have any natural killer cells. And they don't have B cell function because they don't have any T cell function. So all of these different genetic conditions have different characteristics of their T cells, B cells, and natural killer cells. And that's not anything for you to be concerned about now, but the physicians who care for SCID patients can use the presence or absence of NK cells, and T cells, and B cells to guide their genetic diagnosis. And my experience here at Duke over the past 40 years has been that we've seen 218 infants with SCID and the different genetic types that we've seen. You can see over on the far right that the most common type is X-linked SCID, or gamma C deficiency. That's about 46%. The next most common is adenosine deaminase deficiency, or 16%. And then the third most common is IL-7 receptor alpha chain deficiency, which is about 12%. And then there are other conditions that are very rare, like CD3 chain defects, and then CD45 deficiency, Janus kinase 3 deficiency, recombinase activating gene deficiencies, Artemis deficiency, and then there are 22 infants here who we know autosomal recessive because they either have a brother or sister that has a condition. And then there are 9 that we don't even know whether they have autosomal recessive or whether it's just totally unknown. So there's still lots to be learned about this condition. And now most people consider that there are 18 different genes that when mutated can give you this condition. But the 3 most common are X-linked SCID, ADA deficiency, and IL-7 receptor alpha chain deficiency. Unfortunately, in 1968, the year that HLA was discovered, Doctors Richard Gaddy and Robert Good did the first successful bone marrow transplant for infants with SCID. And because they don't have any T cells, they did not have to use any chemotherapy. And they had successful engraftment, and that patient, as far as I know, is still alive. But our experience here over the last 39 years has been that we have transplanted 180 of these infants, and 132 of them, or 73%, survive today. And then the other characteristic of this population is that 90% of them did not have a matched brother or sister. So they had to use a mother or father as a donor in order to get around the problem of the graft reacting against the baby, called graft versus host disease. We had to use a method that was also used at the Sloan Kettering, where you could deplete the T cells from the donor stem cells. And we did this technique in all of these 159 cases. So 111 of the 159 who had a half-match transplant, or 70%, survived. However, and one of the things we noticed first back in 1999 when we analyzed the data was if the infant could be transplanted before 3.5 months of life, 93.1% survived to up to 39 years. So a key point here was if you could diagnose this condition before they became infected, because all the rest of them usually came in at 6 months of age with some severe infection. But if you could do it before they become infected, that they would have an excellent chance of survival. So the characteristics of all of these 180 patients is that they did not receive any pre-transplant chemo. They didn't receive any graft versus host disease immunosuppressive drugs. And all of the donors were related. And all of the patients had classic SCID. And this is the largest single center experience and the highest survival rate anywhere all over. So these are the infants that we treated in the first 3.5 months of life. Sometimes these were diagnosed by family history. Other times we just had an alert pediatrician who noticed a low lymphocyte count. But you can see that of the 58 SCIDs that we treated in the first 3.5 months of life, there were 33 who were X-linked. There were 13 who were ADA deficient, and there were 6 who were IL-7 receptor alpha chain deficient. And then there were others like 1 JAK3 deficient, 2 RAG deficient, 1 autosomal recessive of unknown genetic type, 1 CD3 delta chain deficient, and 1 Artemis deficient. And there are 4 of these patients who are deceased. 1 is an X-linked SCID who died at age 22 because he stopped his IVIG and he had developed severe pulmonary disease. There was 1 ADA deficient SCID who died very soon after birth because his mother had a viral infection that he contracted. And there was 1 IL-7 receptor alpha chain deficient SCID who developed EBV lymphoproliferative disease. And there was 1 RAG2 deficient SCID who died at age 10 years of a central line infection. So all of the rest currently survive, and this brought us to recommend very strongly that newborn screening be done for this condition because it can be diagnosed on the cord blood. So other things that have happened over the last 39 years are that there were multiple reports of multi-center studies in Europe of infants who had been treated with SCID, but there had not been any multi-center reports from the United States or Canada. So in 2010, the National Institute of Allergy and Infectious Disease funded a research grant, which was entitled Primary Immunodeficiency Treatment Consortium, or the PIDTC. Now, this consortium consists of 43 centers in the United States and Canada that have transplanted SCIDs. There were 2 SCID protocols, the 6901 prospective study that began in 2010, and this enrolled all the babies that were born from 2010 to the current time. And then the 6902 retrospective study that included all the SCIDs that were transplanted from 1982 through 2009. And this is a summary of the centers who participated in the retrospective study. And you can see from this slide, the main point is that there are very few of these centers that had had much experience in transplanting SCIDs. There are only about 10 centers that had, over the past 30 years prior to that, transplanted any SCID babies. And there were only 4 or 5 that had transplanted more than 20 SCIDs. The greatest experience was at our center with Dr. Richard Rowley at the Sloan Kettering. And in the 6901 study, there are probably now more than 250 infants who have been entered from 2010 until the present time. And those are being summarized for publication. From the retrospective study, the first report was by Dr. Sung-Young Pai and all of the members of the PIDTC who had transplanted patients between 2000 and the end of 2009. And this was summarized in the New England Journal article in 2015. But the key points from this article in the New England Journal is that if you had a matched sibling donor, you had a 100% chance of survival. If you had a mismatch related donor, such as a mother or father with no conditioning, then there was the next best survival curve. And then there were other types of donors, such as unrelated, and then there were cord blood transplants, and these had the worst outcome. And then in terms of the age of transplantation, you can see that this made a huge difference, because if you could do a mismatch related with no conditioning, then you had almost as good survival as you did with a matched sibling donor. The worst results were with umbilical cord transplants, and then mismatch related where there was conditioning used. If there was no active infection at the time of the transplant, then matched sibling donor outcome was the best. But the next best was like a mother or father with no conditioning. And then the worst outcomes were with conditioning or with cord blood transplants. So again, if you had an active infection at the time of transplant, a matched sibling donor was the best, but a mismatch related mother or father with no conditioning was the second best. And then other donors and umbilical cord transplants and mismatch related with conditioning gave the worst outcome. So these were key points that supported what we had observed in our population over the past 4 decades. So what is the incidence of this condition? Well, it was not known until newborn screening began. Many infants died of infection and were never diagnosed. The death certificate said pneumonia or some other cause of death, but they didn't know what the real cause of death was. But if the infant had received live vaccines like live oral polio, or if they had received a rotavirus vaccine, varicella, or BCG, this led to early demise. So live vaccines were a real problem. And then another problem was that if they received a blood product that had not been irradiated, they would also die early. In fact, within a few days after receiving a non-irradiated blood transfusion. So in January of 2010, the Secretary of the United States HHS Advisory Committee unanimously recommended adding SCID to conditions routinely screened for at birth. Screening now, and all have found SCIDs. And this is the first primary immune deficiency to be screened for. But with modern molecular technology, screening for many more primary immune deficiencies will be possible in the future. So in conclusion, SCID is a pediatric emergency, and the potential exists to diagnose this condition routinely at birth and to successfully treat it. If a rigorously T-cell depleted stem cell transplant from a relative, such as a mother, father, or sibling, can be done in the first 3.5 months of life without pre-transplant chemotherapy or post-transplant GVH prophylactic drugs, And before infections develop, there's a very high probability of long-term success. So T-cell depleted haploidentical marrow transplantation provides life-saving therapy for all forms of SCID, but it's not a perfect treatment. Gene therapy trials are now open, or one is under review by the FDA for X-linked SCID, ADA deficient SCID, and Artemis deficient SCID. And hopefully these trials will be, we know that several of them have been very successful, and we hope that they will soon be approved for widespread use, and that other types of SCID will also go on to have gene therapy available. So that's a brief summary of what's happened over the last 40 years in SCID. Thank you for your attention.